It is my pleasure to introduce our next speaker, Neha Shah. Neha is not just a dietitian, she is a dedicated health education specialist who has been at the forefront of caring for patients with GI diseases, including IBD, short bowel syndrome, and ostomy. What set Neha truly apart is also her commitment to shape the next generation of nutrition professionals, in lecturing fellows and serving as a mentor and instructor to dietitian, the interns at UCSF. I can't remember how many times like our attending our co-fellows have mentioned you. Yeah. She earned her bachelor degree in nutrition from California Polytechnic State University, followed by a master degree in public health nutrition from Loma Linda University, and has been working in the field since 2005. Neha is also a key member of many organizations, including the International Foundation of GI Disorder, Academy of Nutrition and Dietetics, to name a few. Today, Neha will be sharing her wealth of knowledge and experience, providing insight into the complexity of GI nutrition. And thank you again, Neha, for taking the time for the lecture.
Absolutely. Thank you for having me. Like I said, it's an honor to start off my first month of the year with a lecture to the UCSF GI Fellowship. Okay. Can everyone hear me okay? Yes. Okay. So I'm going to go ahead and get started. So again, my name is Neha Shah, and I am a dietitian specializing in gastrointestinal and liver nutrition, even though I don't see liver patients here at UCSF for the past, oh my gosh, 18 years, and I'll be been a dietitian for 20 years in April. So let's just say it's been pretty much my entire career as a dietitian. I've been specializing in this area. So for the purpose of today, we are going to really look at how we can develop your toolkit when you are assessing your patients in a clinic visit. Nutrition goes beyond what diet do I need to instruct my patients to follow on. There's truly multiple elements that a patient can bring in that can indicate signs that their nutritional status is compromised. So with that said, when you have this patient sitting in front of you, it is really important that we are keeping an eye out for all those signs and symptoms that their nutritional status is impaired or anything along that aspect. And we're going to jump right into it. Okay. Here are my disclosures. So for our agenda today, one aspect is as part of the evaluation process, like can we determine when these patients are coming in and how they're coming in, and what is an automated way that we can identify presence of a compromised nutritional status. So it is very important that we do identify presence of malnutrition, physical signs, mental health signs, certainly the presence of disordered eating and eating disorders is actually highly prevalent within the GI patient population. So avoidant restrictive food intake disorder is a disordered eating pattern that I will highlight. And then, food choices are not just determined by, what we like, what we don't like. There's a lot of different aspects that determine our food choices. So how do we screen for the presence of food insecurity, meaning that do patients have enough finances to bring in the foods that we're recommending for them? And how do we optimize those resources? Certainly, screening for nutritional risk versus nutrition assessment, completely two different processes. So when this patient is sitting in front of you, how do we collect objective and subjective nutrition data to really make an assessment and learn the current state of the patient when it comes to nutrition. Nutrition interventions, we can only intervene once we understand the current state. And how do we prioritize this? And certainly, how do we also plan for ongoing nutrition monitoring so we can troubleshoot areas of concern and help the patient keep the areas of strength as well? So first of all, we're going to start with the basics. And why am I including this today is because this is an area of I educate on the basics of nutrition pretty much every day in my practice, and these questions will come up. There's a lot of misinformation out there in the media about carbohydrates, proteins, fats, vitamins, and minerals, and it's our role as a healthcare provider to help dispel myths related to some of these nutrients. And we cannot move forward with helping patients change their diet until they gain a sense of what is the evidence related to nutrition. It starts with the basics. So I'm going to spend just a brief amount of time on this because I do want to spend most of the time on the other aspects of the lecture. But carbohydrates, they're not all the same. There are different terminology out there that can indicate the word carbohydrates. Saccharides, this is the basic term used to refer to carbohydrates, but patients in their mind, they may see carbohydrates as sugar. So when patients come in and saying, I'm limiting carbohydrates because it doesn't make me feel well, my question is, what do you mean? Because there's so many different types. And overall, monosaccharides, this is the glucose, the fructose, the galactose. So a common nutrient that I can highlight within a GI diet is that, fructose containing fruits. We know this is part of the low FODMAP diet. And where are those sources? And these are a single unit of a saccharide. And depending on how many units a saccharide has, also depends on how it's digested and how it's absorbed. So monosaccharides, it does not require any digestive enzymes to break it down. Certainly disaccharides, lactose is a example I will highlight here. This is the milk sugar in dairy. It requires digestive enzymes to break the disaccharide down. And of course, oligosaccharides, these are the inulins, the fructans, the galactans. We don't have enzymes to break oligosaccharides. This is also part of the low FODMAP diet. So no matter what, all human beings will not be able to digest oligosaccharides. So this can pose more of an intolerant concern when patients eat too much of it. That's usually the concern. Polysaccharide, this is your dietary fiber. And it's also the starch, which is digestible, and dietary fiber, which I will highlight in a second, it is not. And then certainly amylases are the enzyme that digest all digestible carbohydrates. And again, this is all part of an education to the patient that not all carbohydrates are equal. So with foods with carbohydrates, it's only in plant-based foods and dairy. So simple carbohydrates, these are your mono and disaccharides. This is your fruit. This is your agave nectar. This is the honey. This is sugar, like table sugar, brown sugar, molasses. Whereas the complex carbohydrates, they pretty much have the starch and the fiber, the grains, the beans, the lentils, the nuts. Another way to outline carbohydrates to patients: carbohydrates with starch, carbohydrates with fiber, and carbohydrates with sugar. And I tend to go over these different categories with the patients and how they relate to the GI tract. Lactose, I will highlight again. Certainly, my main point here is that not all dairy is equal in lactose content. And the reason why is because a lot of patients coming in, they're saying, well, I have problems with milk, so I just completely avoided all dairy. Where as a healthcare provider, if that's their choice, fine. But would you be interested in learning a little bit more about if you wish to bring back dairy, learn a little bit more that not all dairy is equal in lactose, and we can work out options in small amounts to help you do this. And lactose-free products, obviously, it's a separation. There's an enzyme in there to separate the glucose and galactose in the dairy. So this is a chart that I often show patients to highlight the lactose content in the dairy. It's never on the food label, even though there was some talk many, many years ago to include that. But to kind of give you an idea, it's really across the spectrum. And like if they're ordering Thai iced tea at an Asian restaurant or any type of really sweet tea like that, oftentimes condensed milk is used to make that tea. So yeah, if they're finding that they're running to the restroom or having a lot of gas and bloating, maybe that iced tea with that condensed milk may not be the best option. But a little sprinkle of hard cheese, you know, can be, are very low in lactose. So if one is telling me they're having issues with dairy, then, and if they missed eating dairy, then I tend to like bring this chart in and work out some options with patients. Fiber, it is a carbohydrate, a polysaccharide, as we mentioned earlier. We do not digest fiber. One thing I can highlight here is that not all fibers are equal in composition in foods and supplements. So when patients say, I'm avoiding fiber, again, we need to learn what do they mean by that. Various fibers have different functions in the gastrointestinal tract. So with the different properties of fiber, solubility, fermentability, and viscosity, I will ask all of you to remember this slide. I have this conversation about 30 times a week, 6 times a day. So it is something that it really does make a difference and helps the patient expand on fruits and vegetables and whole grains and legumes, but we find GI-friendly options within those food groups to help them eat more fiber. Fiber is tied in with optimizing our gut microbiome diversity and composition, and it can certainly help to, you know, um, you know, uh, promote I guess, the type of bowel movements that are desired to help our patients feel better or reduce gas and bloating. So solubility of fiber, this is the ability of the fiber to dissolve and hold in water. I will talk a little bit more down the line on how this is really helpful for those who have a lot of diarrhea. Sources of soluble fibers in the diet is like the pectin found in fruits or the glucans found in oatmeal. Fermentability refers to the ability of the fiber to undergo fermentation by intestinal bacteria. So examples here is it's really like the fruits. A lot of the fruits are fermentable, garlic and onion. A lot of these fibers are also what we call the prebiotics in the diet. And more fermentable the fiber is, the potential it could be to contribute to a lot of gas and bloating. So again, we need to look at that within the diet. And certainly viscosity is the ability of the fiber to resist flow, slow things down, and form a gel when mixed with fluids, which thickens that fluid. And again, here are lentils as an example of a low viscosity. It's not going to resist flow. And then properties of fibers can overlap in the same food. Okay, proteins. Briefly, again, different terminology. The main thing is that when patients say, like I had a patient, we just went over this like a few days ago on the different types of proteins in the diet, not necessarily all the different language here, but why we need protein in the diet to get the essential amino acids. Essential meaning that our body does not make them. We have to get them from the diet, or, or why pancreatic enzymes target, to help break down the nutrients from the diet into the individual counterpart. So again, knowing the language related to protein and pulling it in can help with that education piece. Foods with protein, they're both in animal and plant-based foods. It's really interesting because when I ask my patients, can you tell me a little bit more, what are the protein sources in your day? And then let me know if you need help, or let me know if you need me to go over what is protein, where we can find it. They always go straight to beef, pork, chicken, eggs, and dairy. And then I'm like, what about the plant-based protein? And then there's like usually a blank look on their face, and they'll ask me, what do you mean by plant protein? And then this is a education key point that beans, lentils, nuts, edamame, quinoa, soy, a chia pudding, they're all sources of plant protein as well. So we want to look for both in the diet. Gluten, it is a storage protein found in wheat, barley, and rye. Gluten, we do not break down gluten in the small bowel. The carbohydrates found in wheat, barley, and rye, it is an oligosaccharide. It is a fermentable fiber, and it is definitely a key focus point when we're trying to help our patients reduce some gas and bloating. Is it the gluten? Is it the fructans that are being bothersome to GI symptoms? And with the gluten, again, this is a cheat sheet where obvious sources of gluten. There's a lot of different terminology out there. So those with celiac disease, I do encourage them, please learn the language related to gluten, where it's not just wheat, barley, and rye. But if you see bulgur, that is gluten. If you see farro, that is gluten, or it could be hiding in certain foods. But those who report to be gluten sensitive but do not have celiac disease, I find how they follow their gluten free diet is variable. And again, it is important to learn a little bit more to what extent they're following this diet. And again, with fats, different terminology with fats. Medium chain fats, we know, do not require digestive enzymes. So it is a key education point with my patients when I'm trying to help them add calories through MCT oil, or why, long chain fats do not digest well, like with pancreatitis or any other disorder that involves malabsorption. Okay. Certainly, again, animal and plant-based fats. It's a key education point with a lot of my patients, where the saturated fats and cholesterol are mainly found in animal-based fats, and unsaturated fats, the avocado, the creamy peanut butter, are usually found in plant-based fats. So again, we want to bring both education key points into the diet, because a lot of patients are not fully aware of the distinction. And finally, with micronutrients, always a hot topic. A lot of my patients come in and they're on so many different supplements. And today's talk is beyond the scope of each micronutrient out there, but knowing the basic categories and how they interact with our body is going to be also helpful in your education with patients. Like the other day, I had a patient who wants to take 1,000 milligrams of vitamin C because she is about to develop a cold. There's very limited evidence to support the use of vitamin C with preventing a cold. And all that vitamin C that she's going to, have, our body has checks and balance systems in there. She's likely going to urinate all that vitamin C out. So that is an education key point that I brought in from that aspect. So fat-soluble vitamins, water-soluble vitamins, macro minerals, trace minerals, throughout the course of your fellowship, we will, a lot of these definitions and characteristics will come into your discussions with your patients. Okay, nutrition assessment, moving right in. So what is malnutrition? Malnutrition goes beyond just weight loss. It's really a constellation of symptoms that we need to keep an eye out for. It is unintentional weight loss of a certain percentage. It's really a decreased intake of calories, a loss of muscle mass, and a loss of subcutaneous fat. A lot patients will come in at different body weights and different body sizes. So it's not always possible to see the loss of muscle mass and loss of subcutaneous fat, but we will go over in a second of how to identify that. And changes in physical activity and strength. Sarcopenia is also highly prevalent in those with diagnosed with GI disorders. And this is, again, something that we don't have the tools to measure in clinic, but when there's a loss of muscle mass or a loss of subcutaneous fat, there's usually a change in physical activity as well. Oops, so sorry, let me backtrack. So there are two primary causes to malnutrition. One aspect is what we call starvation, where there's really no inflammatory cause. This could be related to depression, anxiety, a presence of an eating disorder. Perhaps this patient does not have the funds or finances to access food. There's a lot of food insecurity in here. So naturally, they may eat less, and then it leads to all the symptoms related to malnutrition. Inflammation is a big driver to malnutrition, where inflammatory bowel disease, pancreatitis, those recovering from GI surgery, like say recovering from just getting an ostomy or a gastrectomy, even cancer, trying to think all the inflammatory disorders out there, or status. So overall, this can contribute to malnutrition because of its impact on metabolism, where inflammation just really, the body will break down all nutrients to put it towards the healing process. And there's a huge increase in metabolism to do so. And in turn, the patients through that process will lose weight because of the presence of inflammation. And with screening tools, you know, one day when you have your own clinic and you're an attending, it is so important to have a malnutrition screening tool as part of your clinic questionnaire. We need to be able to have patients select and fill out information related to weight changes. You know, do they have, when they look at their body, are they seeing signs of muscle loss? Certainly, are there issues related to finances related to foods? Like all of this is included as a part of a screening tool. I will highlight the malnutrition universal screening tool today, as well as the subjective global assessment. There's several out there that have been validated in the use of malnutrition, a certain more patient population than others, but yes. So the malnutrition universal screening tool, it has been often used to screen for malnutrition in those with inflammatory bowel disease. It's a really three-step questionnaire to patients where, you know, there could be given a BMI chart where they may indicate, okay, let's see, if you're underweight, there's a score assigned. If you're certainly normal, a BMI, a score is assigned. The limitations of using BMI, it doesn't account for inflammation or starvation. It does not account for body composition. It's just height and weight. Certainly the percentage of weight loss in 3 to 6 months, you know, it's just really telling patients, like asking patients, how much did you weigh 6 months ago? How much did you weigh at 3 months? And how much did you weigh? How much do you weigh now? And then from there, the percentage of weight loss is calculated. And then learning a little bit more about the disease effect, because again, that has an impact there. And then certainly, if the score is over 2, it's a high risk for malnutrition. In the subjective global assessment, this is actually one of my favorite screening tools out there because it does factor in gastrointestinal symptoms and physical activity, changes in physical activity. And overall, it's going to screen for food intake, weight, symptoms, and function. And patients can fill this out, and there are definitely templates out there that it can be incorporated as a part of a you know, a clinic questionnaire, and there is a scoring system as well. But again, malnutrition may indicate significant changes in intake, a weight loss percentage, presence of symptoms, and change in function. And then with avoid and restrictive food intake disorder, this is something that it's really coming up in front where it can certainly contribute to malnutrition as part of the starvation aspect of the contributors to malnutrition. And the biggest thing I can highlight here is that with ARFID, it does not necessarily involve any concerns with body image or weight size, but there's like just a significant hesitation and fear when it comes to trying new foods. I mean, there is a change in relationship to diet, and that's a huge aspect of nutrition. But it's a fine balance because naturally, so if one's having a lot of GI symptoms, they naturally avoid certain foods, but it doesn't mean they have ARFID. It's like it depends on how long it's going on for, the extent of it. So it's really important that we start to hear patients use language. I'm fearful of this. I don't know if I can do this. I tried it, forget it. I want to do it, which is change talk, but I'm not sure how to do it, or this might happen if I do it. That's all fear talking, and we really need to work with that as well. Food insecurity, I already mentioned this before. There's a lot of screening tools out here. This is one of my favorite screening tools because it's just 2 questions. And more often than not, patients have said yes. I worry whether food would run out. There's a significant number of patients in our clinic that are receiving aid from governmental agencies. And now we're trying to work with a specialized diet that they don't have access to with the food. So all comes into mind when it comes to recommending the diet. Now, areas of nutrition assessment, with that said, is patient history, anthropometric measurements, nutrition focus, physical examination, biochemical data, food and nutrition history, and readiness to change. So I'm going to highlight a few here. Certainly with patient history, all of you are already involved in collecting that history from your patients. But the biggest thing is what I look for is the nutritional impact from the patient history. Certainly, I can highlight signs and symptoms that can predict how open or willing a patient is, wanting to add foods back in the diet or really look at different ways of eating to help them feel better. Psychological state, quality of life. There is such thing as food-related quality of life, where significant changes in the diet, it goes beyond the food choices. It has impacted their ability to spend time with their friends and family. Or I definitely have patients who refuse to be around people around the holidays because they're a little nervous that they're going to have symptoms in front of other people. So food-related quality of life is something that, I do keep an eye out for if there is a change in quality of life. And obviously the intake of vitamins and minerals, herbs and spices, pro and prebiotics, all of this can be impactful towards nutrition. Why are they taking all of this? If they are, what are the indications, and so forth. And then certainly social history, the support system. It's interesting that there could be patients can come into clinic or they're on the Zoom visit and they have individuals with them, but a lot of these patients live on their own, and a lot of them have mentioned to me, I know what I'm supposed to do with my diet. I just don't have the energy to cook in the kitchen. I don't have the energy to go grocery shopping. So how do we optimize those resources so we can bring the foods into the kitchen? Food culture is a huge, influence on food choices. Religion will dictate food choices. So I'm looking for the nutritional aspect there. The housing situation, I definitely met a lot of patients that are living in hotels, living with other people, and they haven't been comfortable, like, just overall, bringing foods in when they know it's not their space. So again, or they have just a little mini fridge in their hotel room and they can't store a lot. So again, I'm looking for the nutritional impact. And then certainly weight changes. This is something that dietitian usually will take care of, but an electronic health record can also calculate this. And the reason why I brought this forward is because what they used to weigh before and now what they weigh, that percentage of weight change is really an indicator for malnutrition. A lot of different insurance plans look for this change in our note when we're justifying enteral nutrition and parental nutrition. So this is something that will always be in my note. I just want to highlight the significance of including it in your note because it can help a patient get covered for a particular nutrition therapy. Sample questions that you can have ready to go as a smart phrase or part of your clinic note. I will highlight here certainly what weight would you like to be at, what you feel good at, and what do you feel caused the changes in their weight. It's really important that we help our patients reflect upon like what has caused the change in our weight beyond just inflammation, and then is there something that we can do there to help address the barriers. Evaluation of symptoms. Another talk for another day could be just nutrition for functional symptoms, and then we can go over each symptom. But overall, I look for GI symptoms, as all of you already do, and then certainly non-GI, fatigue, insomnia. They can all contribute to aggravation of GI symptoms. Stress is another big contributor to GI symptoms. I look for excessive thirst because I find a lot of the patients that I work with, if their eating has gone down, their fluid intake has gone down, or if they're having a lot of diarrhea or they're dealing with post-surgical complications that is leading to a lot of loose stools, I do find that they do feel more fatigue and have more thirst, and that's an indication to really work with hydration there. Now, sample questions that we can work with our patients, and again, you're already doing this as a part of your clinic assessment, but the biggest thing is that I really ask this for each symptom. Our gastrointestinal tract is one long tube at the end of the day. So all these symptoms are interconnected on some level. So what I can highlight here is that what symptoms tend to worsen with other symptoms or improve. I'm like, so patients will tell me as an example, I have constipation. Okay, tell me a little bit more. How do you know when you're having this symptom? And we go into there. Or sometimes they'll say, I don't have any constipation, but they're telling me that they're straining, or they're, having a sensation of incomplete bowel movements. So knowing helping our patients understand what that symptom means is important. But going back to the constipation example, my gas and bloating gets worse when I am constipated. I'm trying everything within the diet to, lessen the gas and bloating. I'm like, well, we need to work on the constipation to help you do that. The nutrition focused physical examination, this could be a part of your review of symptoms, where it really visually looking at our patient and looking for physical findings of a loss of muscle mass or micronutrient deficiencies. And we're looking at the skin, hair, eyes, mouth, and nails. I think the Zoom visits makes it challenging to do this, but nevertheless, we can work with our patients and ask the right questions through a Zoom visit to help us do this. Oops. Let me backtrack. This little cursor is a little fast. Okay, so signs and symptoms of loss of muscle mass, and a nutrition-focused physical examination, it is a process out there. There are classes out there. There is a lot of literature out there on how to do this with our patients. And through a Zoom visit, like I said, I don't see their entire body, but I will try my best to do this where I'm looking at their temple region, looking at their clavicle. Can you show me your wrists and your feet? Can you show me your knees in some regard? And I'm looking for any type of prominent bone appearance or depression, or if they have sunken eyes, that's another sign of malnutrition. Or like if you look at the gap between my two fingers here, if this highly indented, this is a sign of malnutrition as well. So there's physical signs that we can look for. These charts are easily available and happy to send them over, but I just want to give you an idea of what is looked for loss of muscle mass. So going back to loss of fat. So with that said, again, the sunken eyes, again, a sign of loss of fat, where we're looking for, again, depression points that they may indicate this. Now, like I said, patients may come in with, different body sizes. We may not always see this, but if there is a significant change in weight, likely there's some presence of this, and we need to be able to look out for this. Okay, so with that said, again, presence of edema, that is a sign of malnutrition. I see this in a lot of the medical notes. I'm not going to overly talk about this today, but again, presence of fluid accumulation is also a sign of malnutrition. Okay, micronutrient deficiencies, again, look at your patients. If they're telling you they have changes of how their eye looks or their skin looks, let's take a look at it because it can indicate signs of micronutrient deficiencies. I would have to say in my own practice, if anyone has significant malnutrition, I will always recommend to check labs for vitamins and minerals because I know they're likely could be depleted along the line. But again, looking at the appearance of skin, hair, nails, and teeth, mouth, or teaching patients how to look out for that can help us optimize this aspect as well. With labs, I will highlight here that labs can be altered in a setting of inflammation. So vitamin labs, going back to our basics of micronutrients, our body, some vitamins, there's a lot of storage of there. Some vitamins, we don't have much storage in there, but overall, inflammation can alter metabolism of nutrients. So because you check a vitamin lab and it's low, it may not mean they're deficient. It could be low because of what they're going through. So it just really a picture in time, a snapshot in time. We need to interpret with caution. And with stages of nutrient deficiency, it starts with patients having a decreased intake in diet, but it may not necessarily impact that particular vitamin. When that intake of that particular nutrient becomes really low, that's when we start to see the low serum levels if it's a true deficiency, and then physical signs and symptoms occur. So when we see actually a true sign of deficiency, they've already been depleted, their intake is way down, and this is really an indication for intervention and coming up with a system to replete and maintain. And these are common labs in GI. I can highlight here, certainly with celiac disease, I always recommend checking a list of vitamins at the time of diagnosis. With IBD as well, because intake is so significantly impacted there, as well as absorption. Pancreatitis, more of the fat-soluble vitamins. Short bowel syndrome, yes, there is a high risk for deficiency of many micronutrients because of the change in absorption. The other aspects of indirect calorimetry, or that's usually often used inpatient, can help measure calories at baseline. This is the gold standard, but we don't have the tools here in the clinic with a handheld one to do this. And then essential fatty acid deficiency. If patients are telling they've been following a fat-free diet for a year, or those with a leak, chances are they could be low with essential fatty acids, and we need to be able to check the status and replete from there as well. Albumin, pre-albumin, both of these labs have been shown to, at one point, and I was trained this way 20 years ago, that these are reflective of nutritional status. We're learning more and more that albumin and pre-albumin are reflective. Any changes in there, any drop in their levels, it's really reflective of an inflammatory process. They're both negative acute phase reactants. Our body makes less overall. So it is not used as a nutritional marker at this point, but it's still helpful to learn what the labs are, because I find the lower the albumin, the more the patient is going through when it comes to recovering from surgery or high presence of inflammation that we need to treat. So with food choices, I already mentioned, it goes beyond what we like and what we dislike. Lifestyle, culture, how much time we want to spend in the kitchen, the skills involved with, culinary aspects, finances, quality of life, health, the media. There's so much out there. So when we are recommending a diet for a patient, this is all going to come in. Do we need to change everything out of all of this to really implement a diet? Or are we looking for ways to integrate a way of eating and meet the patient halfway with their culture or their ability to do what they need to do in the kitchen and so forth, or with their finances? And with food and nutrition history, these are the elements that are collected in a diet history. And overall, what I can highlight here is the common questions I will ask my patients. Can you give me a typical day, what you're eating? And can you walk me through and give me examples of foods that you are avoiding from each food group, and what you are eating more of from each food group, to help me understand? It's going back to the basics, where not all foods are equal to one another. So if they're telling me that they're really gassy and bloated, but their primary fruit 3 times a day is a bowl of cherries and stone fruits, I'm thinking, well, those fruits are highly gas producing. Can we work with substitutions there? So learning the types that come in is going to help you identify where their potential intolerances are. And certainly to highlight fiber, gluten, and lactose. I'm watching the time here. Certainly what types are in the diet, how often it's consumed, what type of textures are they eating, because that makes a difference in GI symptoms. So knowing this information can help us understand the current state of their diet. And then sample questions that you can include and ask your patient. These are common questions, like I said, I ask. Give me examples, again, of the types of the foods you eat from each food group, and it helps me understand the type of fiber coming in, the amount of lactose coming in, and so forth, and helps me understand the potential tolerances and intolerances of the diet. And then certainly eating as a behavior at the end of the day. I find most of our GI patients, they tend to, they know that there's an issue, obviously, but they either are fearful of making changes, or they're like, I'm not feeling well. I have to make changes in my diet right now. And they made a lot of changes, but they've removed so much from their diet. So our goal is to really identify the stage of change. Are you ready to make a change in your diet? So sample questions that you can ask your patients. And the biggest question I will highlight here is that, what do you need to help you move forward? That's usually a starting point. They usually have a pretty good idea what their needs are and what they feel like what they need to help them move forward, and where they would like to start is the point of intervention. So with interventions, again, once we learn the current state, how do we plan for interventions? We may need to break it down in several appointments, and this is where it's appropriate to refer the patient to the dietitian. But what can you do in that appointment with your patient to talk about one intervention that you can focus on? So what I will highlight here is that, do we want to use a formal diet? This could be a gluten-free diet. This could be a low FODMAP diet. Oh, you have IBD. Let's talk about the Crohn's disease exclusion diet. We need to look at the evidence, the status of the diet, and the ability to implement. Going back to the other slide where there's so many different influences on our food choices, can the patient make changes in all of that to implement a diet, or are they willing to do that? Where do we just want to focus on adding nutrients? So a lot of the times I don't use a diet like per se in my practice. I really look at what's coming in from each food groups, and can we work with, oh, I see your diet's already low in fiber. Can we bring in this type of fiber to help this type of symptom? And let's start there. And all of them, most of them, have been greatly appreciative that I worked with a subtle approach versus a long list of foods, do's and don'ts, and from that perspective. But it has to match with the patient's goals as well. So quick highlights from that perspective is that, say patients come to you and saying, I am dairy free, but I would love to add a little bit of dairy. What are your thoughts if I could try a little bit dairy? And here are some strategies that you can offer to your patient that there is no need for a dairy-free diet. You can start with low lactose and lactose-free based off that chart that I showed you earlier of the different amounts of lactose from there. Smaller portions, it's really treating that dairy like a sprinkle, a slice, a dollop. If they're telling you that the reason they gave up dairy is because they had yogurt with fruit and cream in their coffee and milk with their scrambled eggs and they didn't feel well, then too many all at once is something I look for at a meal. Like, how do we go less versus eliminate altogether? And dairy is not needed at each meal. So these are some strategies that we can work with our patients to help them with their improve eating with dairy. Gluten, oh, I get this question all the time. I am gluten-free, but do I really need to be? I miss eating my favorite foods in restaurants, and I don't like the taste of gluten-free bread. So these are my strategies of how to help someone add a little bit more gluten, where maybe their diet is still gluten-free, but once a day, there's one gluten-free food coming in that they can bring in, and it's all about the dose, the portion as well. There's no need for gluten at each meal. So these are some strategies I can share with you if patients are asking you how to add gluten. Fiber. Oh, a hot topic is that, going back to what I was saying earlier, there are different properties of fiber, solubility, fermentability, and viscosity. When it comes to fiber intake, it always starts with soluble fibers. And then fermentability and viscosity comes in depending on where their symptoms are at. So if a patient's coming in and they're saying they're having a lot of diarrhea, and they don't want, like, a lot of the time they'll come in with diarrhea, like irritable bowel syndrome with diarrhea, and they're being given the low FODMAP diet to follow. And they're like, I can't do this diet. It requires so many changes in my lifestyle. And then this is where we tend to talk about the solubility of fiber, how it can help thicken and add bulk to stool. So a common strategy is, here are the sources of soluble fiber. Can we add a little bit to each meal? Can we explore a soluble fiber supplement? I find this works just as effectively. Insoluble fibers, they tend to speed up bowel movements. That's what they do, which is fine. But again, it may not be most appropriate for those with diarrhea, but it can be very helpful for constipation to move things along. But we need the soluble fibers to soften the stool to make it easier to pass. So with constipation, it's a mix of soluble and insoluble fibers to each meal to get the best of both properties. And if they have a lot of gas and bloating, then it's going to be low gas producing fibers as a part of this. So like oatmeal and banana, they're low gas producing, where something like apples and watermelon and peaches are higher gas producing. Maybe those fruits are not the best option if they're already having a lot of bloating with their constipation. And of course, like I just said, if they're having a lot of bloating, then it's going to be low fermentable fibers. And this is where it's, it's a lot of information on the different types of fibers here, but I can't stress enough. The more I can empower you to learn the different types of fibers, the more it's going to help you with your discussions with your patients. Okay. So with that said, I'm going to wrap it up soon. Quick strategies on weight gain, weight maintenance. Patients will come in with weight loss, with GI symptoms. How do I help myself? How do I gain weight? Protein at each meal of what they're doing already, because, or having a mix of liquid and food calories. Asking your patients if they'd be open to adding a smoothie. And if they don't know what a smoothie is, that came up last week. It's okay. Explain to them what a smoothie is, or a ready to go protein shake at least once a day. Can we add an extra snack into the day, or what they're already having in their diet? And all that can help enhance what the strength in their diet right now. Increasing the portions by an extra 1 tablespoon is really my 2 thumbs put together. And you'll see that I've kind of capitalized 1 tablespoon is because the portions are really small, and I hope it does not induce fear. So we want to take this in small strategies. With adding foods back, say someone comes to you saying, I've been on the low FODMAP diet for 6 months. I don't know how to add back foods. I can't get in to see the dietitian. What are some of your ideas? This is exactly what I do here. So pick at least 3 meals in the week, make a list of foods that you want to try, pick 1 new food from one food group. It could be 1 low FODMAP fruit, and do this in small amounts and just practice this until, and then we can move forward with other foods. And I find this to be very effective and for patients who want to try things on their own. But again, guidance is needed so they stay nourished during this process as well. And small particle size, blend, chop, mash, mince, it all makes a difference in tolerance. So if a patient is telling you, I don't tolerate raw, okay, can we cook it? Can we blend it like in a soup or a smoothie? There's different ways that we can incorporate this. And I find that has been also helpful. Not every aspect of their food has to be in this blended minced mash consistency, but some foods can be very helpful as well. And with substitutions, again, I find so an example I can highlight here, there's a significant number of patients in the clinic who are following like a low carbohydrate diet and as an effort to lose weight. And then they're going to come in and say, I have a lot of constipation and have a lot of bloating. My suspicion is that they have removed so much of the fruit and the grains and the legumes to follow this low carb diet that their diet is actually like a low fiber diet as well. And all they eat is vegetables, which is like a lot of insoluble fiber. And with constipation, again, highlighting that is that you need to bring in the soluble fibers to soften the stool. And then you can bring in also the insoluble fibers to stimulate bowel movements. But if all they're eating is insoluble fibers, and they're telling me they're having a lot of cramping, they have this urge to go, but they can't go, then we need to be able to soften that stool. So just making substitutions, if they're willing to, it's a combination between adding foods and making substitutions. So if they have a lot of constipation, then can we substitute some of your plant-based foods with more soluble, insoluble options and amounts that you're comfortable with? Or you're having a lot of diarrhea. Can we, make a substitution for your, instead of your cream of wheat in the morning, can we add an oatmeal instead? So these are some ideas here that I tend to work with. Yeah, so with that said, moving forward, and small frequent meals, patients will ask me, what is a small frequent meal? I'm told to eat small meals, but I don't know what that means. So a lot of the times in our conversations with patients, we talk about the end goal. Eat 5 portions of fruits and veggies in the day, do 3 to 6 small frequent meals in the day, follow a low FODMAP diet. But what we need to have conversation with, how do we break this down? How do we define? So this is my definition of a small frequent meal. There's no definition out there of what a small meal is, but some patients think a small meal might mean a snack, and they're telling me they're really hungry afterwards. And the biggest thing is that I really teach my patients to start with small portions and do not put any more second helpings on that plate until you're done. I need to assess how you're feeling. Do you want more food? But I will also have to say that those with highly inflammatory GI disorders like IBD or pancreatitis, the inflammation can also suppress hunger in some ways. They're not hungry, or if they have a significant change in relationship to food, they're not motivated to eat. They don't feel hungry. They have a huge loss of appetite. And if you're coming across this, then it's helpful to even ask your patients can we schedule meals in particular time frames to help you anticipate food during that time so you still continue to eat. And then we work with the small meal concept here as well. And again, a concept of one at a time. So practice is a key word here, with one meal in the day. Use one meal to add new foods in while you continue with your other elements of your diet on the other meals of the day. And I will wrap it up with, referrals to care. We're all one team here. So obviously I am the dietitian in the clinic, and I work with my patients beyond just exploring foods, but really working ways to improve that relationship to diet and optimize nutrient intake for nourishment. But a gastropsychologist, a social worker, a physical therapist, like a pelvic floor physical therapist, we're all in this together to really address what is getting in the way of this diet. And I think that change in relationship to foods, I'm certainly not a specialist in eating disorders, but we can see signs of it. And then we really need to bring in the help of a psychologist as a highlight to help address food related anxiety of related to eating, or a social worker can help a patient fill out or optimize resources to reduce food insecurity, as in another example. And then with that said, I'm going to end it right here. Obviously, depending on what the priorities that we set with nutrition assessment and nutrition intervention, it will guide how we want to monitor. And then what I will encourage all of you to do today is, like, what is one element here that you can bring into your toolkit in your discussions with patients regarding nutrition? And I will end right here, and I'm happy to answer